And welcome to our vertical integration number 2 for this year. My name is Jenny Pearson. Before we go any further, I'll just get everybody to mute their microphones if they can. I'd just like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. And I am coming to you from Anawan land in the Northern Tablelands. This session is being recorded. Today's topic is navigating MBS billing numbers, and our presenter is Heidi Avery. Heidi is a Primary Care Improvement Officer for the Primary Health Network. If you have any questions, don't forget to type them into the chat box. Heidi's very generously agreed if we don't get time to answer them all, that she will reply via email to everyone so we can see them all, and that'll be great, but please type them in. If you all can mute your microphone. At the end of the session, we have our Slido evaluation. I have put the link in the chat box, but I will put it in right at the end so it's easy for all of you to find. And I'll just hand over to Georgia.
Hi everyone, welcome again to our second vertical integration session for the year. So we've got a great topic today, which, if there's any medical students or interns on board, they'll think, what is the MBS, how does that work? But there'll be something in it for everyone today. So it's important to be aware of how it works in general practice, that we are small businesses and our income is based on billings when we see a patient. So we don't get salaries like hospital doctors. So hopefully this will give you an insight into how it works with billings in general practice. And for the registrars and the GPs out there, I'm sure you'll get some really great tips. There'll be some that will be revision, but I know it's a minefield out there trying to navigate the MBS. So if you have any questions, please write in the chat box and enjoy. So I'll hand over to Heidi.
Thanks, Georgia. Welcome, everyone. Thanks for joining us today. We've also got Sarah Houlihan sitting there in the background. So Sarah is a Primary Care Improvement Officer at the PHN as well. So between the two of us, we should be able to answer your questions. So, okay, so we do have a pretty full content today, and why is my slides not moving? Okay, so today we're going to look at the Medicare and the billing, services that don't attract Medicare benefits, the Medicare safety net, recording of clinical notes. We'll go through and I'll show you how to use the MBS online. We'll briefly discuss chronic disease management and health assessments. We're only going to be looking at the MBS component to that, not actually how to do the assessment. We'll look at the COVID-19 temporary MBS services, some skin services, mental health, and then we'll finish up with some resources. So I will move pretty quickly through these slides because we have got a lot of content today. So we'll look at the Medicare and the billing. So in Australia, general practices essentially operate as private businesses. So payment for services involves an agreement between the GP and patient on a fee-for-service basis. So patients are supported in paying their medical costs through third-party insurers such as Medicare. So practice billing policies will vary between practices, and some practices may bulk bill some or all of their patients, while others may privately charge. So bulk billing is when a doctor bills Medicare directly for the services provided, so the patient has no out-of-pocket expenses. So if bulk billed, you cannot charge for any additional costs such as administration, booking fees, or fees for consumables such as bandages. There is an exception to vaccines though. So I'll talk about those a little bit later on. So private billing, operating as a private business. So GPs are free to determine reasonable fees that are reflective of the services that they provide. So different GPs will charge different fees. So where a practitioner provides a number of services on one occasion, they can choose to bulk bill some or all of these services and privately charge a fee for other services in excess of the Medicare rebate. So services that do not attract Medicare benefits, so issuing of a repeat prescription when the patient does not attend a consult, non-therapeutic cosmetic procedures, if it's for a compensation injury or illness for which the patient's insurer or compensation agency has accepted liability, medical examination for the purpose of life insurance and superannuation. So that one, for a medical examination, if the patient has come for their annual license review for a medical reason, like if they're a diabetic or they're over a certain age, that is covered under Medicare. But if it was a medical for a driver's license for work-related purposes, well then no, that's not covered. Also, mass immunisations. So there is an exception to the COVID-19 vaccination, but there isn't for flu vax. So although Medicare benefits are not payable for the issue of a death certificate, an attendance on the patient at which it is determined that life is extinct can be claimed under the appropriate attendance item. So the outcome of the attendance may be that a death certificate was issued. However, Medicare benefits are only payable for the attendance component of the service. So now we'll look at the Medicare safety net. So how does the Medicare safety net work? So when an individual or a family's gap payment exceeds a certain threshold amount in a calendar year, 100% of the Medicare benefit schedule fee for an out-of-hospital service is reimbursed through Medicare. So however, this is not necessarily 100% of the out-of-pocket costs, as the treatment fee may be higher than the schedule fee, which means there could still be some expenses to pay. So we have the extended Medicare safety net benefits, and they are paid in addition to the standard Medicare rebate and any benefit received through the original Medicare safety net. So it does get a little bit confusing. So out-of-pocket costs, so they are the difference between the doctor charges and the Medicare rebate for a service. So that includes the general practitioner, a specialist attendance, and many pathology and diagnostic imaging services. So the EMSN benefit is capped, and that only applies to out-of-hospital services. So under the EMSN, once the annual threshold is met, Medicare will pay up to 80% of future out-of-pocket costs for any eligible out-of-hospital services. For the remainder of that calendar year, so they will get a fair proportion of their out-of-pocket costs covered. So a limit or a cap exists for a small number of services, including obstetric, assisted reproductive technology, and consultations with GPs, specialists, and allied health professionals. So it does get a little bit confusing, but this next slide will hopefully explain it a little bit easier. So you have your threshold amount, and so everyone is entitled to the Medicare safety net, so the original and the extended Medicare safety net. So the first component is 100% of the schedule fee of the $495, and then you have the 80% of the out-of-pocket costs for the to the $2,249.80. Then you have the family benefit, so family tax benefit Part A, so they get 80% of that as well.
Heidi, there was just a question regarding flu clinics that you can't, can we not bill Medicare if we do a specific flu vaccine clinic? From my understanding, it's only if the doctor actually delivers the clinic, not the nurses, whereas with COVID, we've been able to bill with the nurses. Is that
So
correct?
yeah, so you can bulk bill. Sorry, I should have been a bit more specific with that. So if you've got a clinic running in your practice, that's fine. But if you're doing a mass vaccination clinic off-site, so if you're going to a workplace somewhere like that, you wouldn't be doing a bulk billing. It would be privately billed. Does that answer your question?
Yeah, I think that probably answers part of the question. And the other thing I think to be aware of, like with the COVID vaccine clinics, we've been doing mass clinics where we can bill Medicare even if the nurse is involved and the doctor's on site. Whereas from my understanding with flu clinics, for it to be billed under the doctor actually has to physically see them.
That's
It can't
correct.
just be the nurse doing the vaccines in another room. The doctor needs to be involved.
Yes, absolutely. And it all, like everything needs to be documented as well. So if the doctor is seeing the patient, that needs to be documented as well as with the nurse. So recording clinical notes. Oh, sorry, did I? Oh no, I was just checking I didn't skip a slide there. So recording a clinical notes. So all practitioners who provide or initiate a service for which a Medicare benefit is payable should ensure they maintain adequate and contemporaneous records. So only clinical details recorded at the time of the attendance counts towards the time of consultation. It does not include information added at a later time, such as reports or investigations. So each entry needs to provide clinical information adequate to explain the type of service rendered or initiated. And each entry also needs to be sufficiently comprehensible that another practitioner relying on the record can effectively undertake the patient's ongoing care. And the clinical record should be completed at the time that the service was rendered or initiated or as soon as practical afterwards. So that is a accreditation requirement as well as MBS. So with MBS online, so when determining appropriate MBS items to bill, you should refer to the relevant MBS item descriptor and explanatory notes available on the MBS on the Department of Health website. So this is just a screenshot on how to actually look up something on the MBS. So you would put something in, like your item number, in the little search bar at the top. And then that would open up. So on this one, for example, we've searched at item 23. So where you can see my little red ring there, there is explanatory notes. So it normally starts with 2 letters and 2 numbers. So you would just click on that little link there. So this section here is your descriptor. So it's a brief overview. Then once you click on your little explanatory notes, it opens up to the full explanatory notes on your criteria, how to bill basically. So it is really important that you do have a read of those just to ensure that you are meeting the requirements. MBS also offers a Ask MBS email advice service. So Ask MBS responds to inquiries from providers of services listed on the MBS. So seeking advice on the interpretation of MBS items, including those for dental pathology and diagnostic imaging, explanatory notes and associated legislation. So this advice is intended is intended to assist health professionals, practice managers and others to understand and comply with the MBS billing requirements. So Ask MBS works closely with policy areas with the Department of Health and with Services Australia to ensure that you receive adequate and up-to-date information. So if you have a query relating exclusively to interpretation of the schedule, you should email askmbs@health.gov.au and then they will respond. Usually it could be a couple of weeks though before you get a response. So Ask MBS issues advisory summaries, summarising responses to frequently asked questions on specific subject areas. So I've also put the link in there as well. So you will get copies of these slides. So yeah, so just jump on and have a look at what's in those links. So we'll move across now to the chronic disease management. So chronic disease in your practice, you've got your preventative and health promotion. So it does reduce the hospital admissions. It boosts income to your practice because your practice is a business. So you do need to consider that. And it does give exceptional patient care and experience. So this chart here will just give you an overview of what falls under your chronic disease management. So you've got your GP management plans and your team care arrangement. So that encompasses your care plan. So they can be claimed every 12 months. Then you have your contribution to your care plans, whether it's in a residential aged care facility or not, and they can be reviewed every 3 months. And then you have just your standard review of your GP management plan or your contribution to, the coordination of your team care arrangement. And that can also be done every 3 months, a minimum of 3 months. So there are exceptional circumstances if a patient does require it out of that time frame as well, but you just do need to annotate that in your billings. So the team care arrangement, so what does collaboration mean? And this area, it does become a little bit tricky. I do see a lot of practices not claiming this step correctly. So, so GPs are required to collaborate with 2 or more other health or care providers in the development of the team care arrangement. So to be one of the minimum of the 3 members of the team care arrangement team, a provider should have an ongoing role and involvement with the patient. So collaboration means communicating with the other providers to discuss potential treatment or services that they will be providing. So only one specialist or a consultant physician can be counted towards the minimum of the 2 contributing team members who, with the coordinating GP, will make up the core team care arrangement team. So communication must be 2-way, so preferably oral, or if that isn't practical, then written. So that can include faxes or emails. So it should relate to the specific needs and circumstances of the patient, and the communication from the collaborating providers must include advice on treatment and management of the patient. So collaboration should relate to the specific needs and circumstances, and a blanket agreement to participate in the team care arrangement would not be sufficient in itself to meet this requirement. So I know it doesn't really make sense in general practice for you to be ringing like an allied health provider every time you have a patient wanting to do a team care arrangement. But unfortunately, that is the rules of Medicare. So that is part of the collaboration.
Yeah, Heidi, we just have a question. If a GP
Yep.
Elsewhere has started a GP management plan and then that patient moves to another practice, can they do a review in 3 to 6 months, or do they have to start a new one?
No, they can review it. It depends on the circumstances, I guess. Depends on whether there has been a significant decline in the patient's health. You will need to annotate that in your billings. It would be easier to review it first and then later on when your 12 months is up, then claim it. Because you probably will be going backwards and forwards a bit with Medicare to get it like it approved.
And I know I've had times where I've done a management plan on a new patient, not realising that they had one done elsewhere.
Yeah.
and the 721, 723 bounces back, and
Yeah.
that's when I'll do the 732, 737.
Yeah. Yeah. You probably would be better off just reviewing it, and then like tweaking it to the patient's needs that way. And then when the 12 months is due, you also, if you have access to Proda, you can go into Proda and check to see when, like, if the patient is eligible for a new review, a new team care arrangement, or whether it is only a review. So that, sorry, I probably should have put that in my slides as well, but I wasn't thinking at the time. But yeah, that is also a really good tool just to check, to cut down or to eliminate your billing errors as well. So
yeah, the My Health Record's very handy for that too. And can your practice nurses be included in the team care arrangement? So if you had another specialist and a practice nurse and the GP, would that be cool?
Under certain circumstances. Sarah, are you still online? Did you
I am. I just answered it in the chat.
Did you?
Yeah, so basically, if the practice nurse is providing the care under the GP, doing things like ECGs or administering medications, then generally no, because that's considered as the GP service. However, if you've got a nurse who provides something independent, like a credentialed diabetic educator, then obviously that is independent of the GP, and then they could be one of the core team.
Thanks, Sarah. Any other questions so far, Georgia?
What area of Proda can we see if the GP management plan has been done?
Oh gosh, put me on the spot now.
Yeah, I'm not sure either. I usually go through.
I know it's the pink. I think it's the online service. Can I get back to you? I have got it on my screen at the end. I'll just look it up and I'll show you. It's under the pink tile, but I can't remember the name of it.
I'm happy to go into that more too when we do the chronic disease and health assessment session specifically.
That'd be good. Thanks, Sarah. So it is the online, MBS online lookup or something. I can't remember exactly what it's called. It is under the pink tile on the GP Proda site anyway. So, but we will cover that a bit later on. Health assessments. So here is a list of your health assessments that you can claim. So you do have your type 2 diabetes OSD risk. So that's done once every 3 years for eligible patients. So for an eligible patient, I would be focusing on doing it at, say, 40, then again at 43, then at 46. And then you can do your next assessment, which is your 45 to 49, and I would be doing that at the 49 mark. So then that way you're maximising those 4 assessments. Then you have your 75-year-old health assessment and a comprehensive medical assessment. That's done in residential aged care facilities. They're annual ones. And you've also got an intellectual disability assessment, the refugee assessment, and also the former serving members of the Australian Defence Force. So they're all eligible, like for eligible patients annually. Sorry, I've rephrased that. The refugee and your Defence Force ones are once only, but the others are all annual. You've also got a 715 health assessment. So this assessment is available to all people of Aboriginal and Torres Strait Islander descent. So this is an annual health assessment which can be claimed after 9 months and 1 week. So it's 40 weeks. Just keep in mind it is 40 weeks, so you've got to add that extra week. In the MBS, it only states 9 months. So yeah. All eligible patients are entitled to be registered for CTG. So this is a once only registration, and that is also done through your Proda account as well. So If your practice is registered for the Practice Incentive Program, patients over the age of 15 years of age with a chronic condition can be registered for the PIP Indigenous Health Incentive annually. So registration for that is a two-step process done through HPOS as well.
Just a question, Heidi, just regarding the health assessments. Can they be billed concurrently with a standard consult? So
Yes, they can.
So I thought health assessments couldn't be, you couldn't do like a 707 with a standard consult like a 23, can you?
You can, as long as they're not related. So, and you will need to annotate that in your billings. So, yeah, so as long as it's, so if a patient, for example, comes in with an ear infection, that is not related to the health assessment, well then yes, you can bill both, but it all comes down to documentation. So making sure you do document in your notes that they are not related conditions, and then yes, you can bill.
And my understanding is if they're due for a GP management plan, because obviously it's usually a comprehensive assessment, you can bill a GP management plan and team care arrangement at the same time as the health assessment also?
Absolutely. Once again, it all comes down to documentation. So the only things that you cannot claim together are a consultation, so a time-based consultation with a care plan, so a 721, 723, and a time-based consultation with a cycle of care. So you wouldn't claim like a time-based consultation with a diabetic assessment.
Yeah. And then just one other question, sorry, just from John, just with getting the communication back to be able to build a team care arrangement, is a letter back from the specialist, is that adequate to count as communication, or does a specialist have to write that they're happy to be involved in their chronic disease management?
Look, it's a tricky one. I'm not clinical, so I wouldn't like to say yes, that is sufficient. Medicare does state that you do need that two-way collaboration. So the provider should be initially telling you what they can provide, what services and treatment they can provide your patient. So if that means that you need that up front, well, yeah, you do need for the specialist to say that, yes, they are happy to participate. Look, some people, and Sarah, you might like to jump in on this one as well. Some people say that when a specialist gives an appointment, that's basically saying, yes, they are agreeing to be part of their involvement. It's a really tricky one.
I guess it's looking at the intention behind what Medicare is specifying for the when they say collaborating with. So because it's rather than just saying, you know, we're sending this patient to the cardiologist and they're part of the team, it's what is the cardiologist going to provide? What is the GP going to provide? What are the allied health providers going to provide? So that's where we're looking more at the specifics of who's going to do what so that nothing gets missed.
Thanks for that, Sarah. That's great.
Yeah. And there was just one more question just regarding the billing codes for the health assessments, so 703, 705, 707. Is it the same billing code for the diabetes high risk 40 to 49-year-old health assessment, the 45 49-year-old and the 75-year-old health assessments? From my understanding, it's the same, all the same numbers, just depending on the time.
Yeah.
And that's cumulative time, from my understanding, of the nurse spent and then spent with you, whereas other assessments, it's only time-based with the doctor.
Yeah,
correct?
That's correct. And when you're billing those item numbers like your 703, 705, 707, you do need to annotate what the assessment was for. So this comes back to like your practice management team. So they would have already set up in the software, and it's just a matter of clicking on the right assessment for that item number. Happy to move along or? Yep. Okay. So diabetes cycles of care. So these item numbers are your 2517, 2521 and 2525. So it is important to do an annual cycle of care to identify any health concerns early and discuss the best treatment with your patient. So the benefit of using the diabetic cycle of care item numbers allows you to build a cycle of care at the same time as a care plan. So as I indicated a little bit earlier, so you can use multiple item numbers if that's warranted. So I've just listed here all the components to the cycle of care, because you do have to have like 6 monthly reviews, yearly reviews, and 2 yearly, like there's requirements to that cycle of care. The Diabetes Annual Cycle of Care is a checklist for reviewing your patient's diabetes management and general health. So you will do this to reduce the risk of diabetes-related complications. You've also got your asthma cycle of care, so your 2546, 2552 and 2558. So the asthma cycle of care involves at least 2 asthma-related consultations within 12 months for a patient with moderate to severe asthma. So noting that at least one of these visits, the review visit, must be planned. So these visits will include document diagnosis and assessment of asthma severity and the level of asthma control, the review of patients' use of and access to the asthma-related medications and devices, and provide a written asthma action plan or documented alternative if the patient is unable to use a written action plan, and provide asthma self-management education and review the written or documented asthma action plan. Then you got your medication reviews. So this is item 900. So this is also known as your home medication review. So it's intended to maximise the individual patient's benefits from their medication regime and prevent medication-related problems through a team approach. So improving the patient's GP and preferred community, it's involving the patient's GP and preferred community pharmacy or accredited pharmacist. So to qualify for a medication review, so they're targeted at patients who are currently taking 5 or more regular medications, taking more than 12 doses of medication per day, have a significant change in their medication treatment regime in the last 3 months, taking medication with a narrow therapeutic index or medications requiring a therapeutic monitoring, experiencing symptoms suggestive of an adverse drug reaction, displaying suboptimal response to treatment with medicines, suspected of non-compliance or inability to manage medication-related therapeutic devices, having difficulty managing their own medicines because of literacy or language difficulties, if any cognitive difficulties, and attending a number of different doctors, so both general practitioners and specialists, and also if they've recently discharged from a facility or a hospital in the last 4 weeks. So when I was in general practice, we were doing medication reviews regularly, and it was probably the most important assessment that we could be offering our patients at that time. We found that nearly every patient that had a medication review had a problem. So whether it was when generic branding came in, lots of patients were confused. They were doubling up on medications. We had a lot of patients that would they would stop and start the medication to suit themselves. So they would never finish a course of antibiotics. They'd put them back in the cupboard and save them for another day. They'd be taking the husband's or the wife's medication or out-of-date medication. So it was quite alarming, the number of problems that arose from doing a medication review. So it is a really important part of the patient's health journey. So claiming the medication review, it is a 3-step process, and you start with by issuing the referral to the pharmacist. You discuss the review findings and the report, including any suggested medication management strategies with the reviewing pharmacist. So they will send through a report, you will read it, and then have that discussion or report back to the pharmacy on what you think, whether you agree or you disagree. And then you would have a discussion of the written management plan following a discussion with the patient. So at that last step, that's when you would be reviewing, that's when you would be billing the medication review. So it is a quite substantial fee for a medication review, but it's something that you could incorporate quite easily into your workload. So doing like you do find a lot of problems with elderly patients. So incorporating that medication review in as part of a 75-year-old health assessment, for example, is a really good time. Also, patients like diabetic patients that are taking quite a few different medications, it's always quite beneficial for those people as well. So that's your medication review. Moving on now, we'll look at the telehealth, the MBS telehealth services. And so from the 1st of January this year, MBS, patients' access to telehealth services will be supported by ongoing MBS arrangements. So they have extended the telehealth services due to COVID. So ongoing arrangements build on the temporary telehealth items introduced as part of the government's response to the COVID pandemic, and will continue to enable all Medicare eligible Australians to access telehealth video and phone services for a range of out-of-hospital consultations that can be provided in person. So a service may only be provided by telehealth where it is safe and clinically appropriate to do so. Bulk bill GPs and other medical practitioners COVID-19 telehealth services are eligible for incentive payments when provided to Commonwealth concession card holders and children under the age of 16 years of age. All providers are expected to obtain and document informed financial consent from the patients prior to charging private fees for any telehealth services. So that's really important to make sure you document it. So who is eligible? So it remains a can't get my words out. It remains a requirement that GPs and other medical practitioners working in general practice can only perform the telehealth service where they have an established clinical relationship with the patient. So with limited exemptions. So a service may only be provided by telehealth where it is safe and clinically appropriate to do so. So bulk bill GP and OMPS COVID-19 telehealth services are eligible for an incentive payment when provided to the Commonwealth concession card holder or children under the age of 16, as I said earlier, and all providers are expected to obtain financial consent. So an established relationship means the medical practitioner performing the service has provided at least one face-to-face service to the patient in the 12 months preceding the telehealth attendance, or is located in a medical practice where the patient has had at least one face-to-face service arranged by that practice in the 12 months preceding the telehealth attendance. So that is including services performed by another doctor located at the practice or a service performed by another health professional located at the practice. So such as a practice nurse or Aboriginal or Torres Strait Islander health worker. Or it is a participant in the approved medical deputising service program, so the after hours. And as long as the medical practitioner has a formal agreement with the medical practice that has provided at least one face-to-face service to the patient in the 12 months preceding the telehealth attendance. And the established relationship requirement is a rolling requirement applying to every telehealth consultation. So for each telehealth consultation, the patient must meet one of the eligibility requirements outlined above, unless one of the following exemptions apply. So, the exemptions, the established relationship requirements don't apply to children under the age of 12 months of age, people that are homeless, patients receiving an urgent after hours service, patients of a medical practitioner of an AMS, people who are in a COVID-19 Commonwealth declared hotspot or in isolation, under the public health order or in quarantine, they are exempt as well. And also patients accessing specific MBS item numbers. So for bloodborne viruses, sexual and reproductive health consultations, there are new item numbers for those group of patients. Also for any pregnancy counselling services, mental health services, they've had a big extension to the telehealth, and also nicotine and smoking cessation counselling as well. So assignment of benefit requirements. So you do need your patient's agreement to bulk bill the items before Medicare can pay you the benefit. So you can get the patient's agreement either in writing by email or verbally in the consultation. So if you get a verbal agreement from your patient, you must write unable to sign in the patient signature field, or why the patient is unable to sign in the provider field. So for example, you could put in there COVID-19. You must keep a record of the agreement, and by getting the verbal consent, it's a temporary policy measure, and this also finishes on the 30th of June 2022. So look, it may get extended, but at this stage there is a cut-off to that in June. So that is a really important step for auditing purposes. So you don't want to get audited and then find that you have you've missed documenting that. Now we're going to.
Sorry, Heidi, there's just a few more questions regarding
sure.
the telehealth. So can we do mental health care plans by telephone now, or do they still require a video consultation? From my understanding, it's a video consultation.
Yes, it is. So I will be covering a little bit more on mental health soon, but yes, there is a list of if you. I have shared the link towards the end. But if you do go into the Medicare website and click on the fact sheets, it does have a really good table there on all of your item numbers for mental health and consultation item numbers, and it will actually tell you whether they do require a face-to-face consultation, whether they can only be done through video conferencing, or whether they can be done on telephone. So that is a really good fact sheet to make yourself familiar with. So yeah.
And there's just another comment about it's very hard to consent in writing for telehealth. So as you said, that after June, verbal consent will no longer be accepted. So it's going to create a lot of red tape if we have to get sign consent when they're actually not attending.
Yeah, it is difficult. Medicare have done a bit of a template that you can email to a patient for them to complete and email back. Look, that's going to be difficult for a lot of patients, especially a lot of elderly patients that aren't tech savvy, don't have access to computers, things like that. Look, I am confident that while ever telehealth for COVID is still available, they may extend it. But I guess we just have to wait and see come the end of June.
And there certainly is a big push for video calls, and you know, I've had many conversations with Dimity. She's got a lot of patients that are very elderly, and it's impossible to do video calls. So that's been really tricky. And Ian's made the comment of, where is the research that video telehealth is better than a phone consultation, or was this rule introduced to rein in costs? So do you know much about the background of that or the evidence?
No, I don't. Sorry. Yeah, look, I'm not clinical, so I don't know. I don't know where that stands. I don't know whether Sarah, whether you have any comments.
And so I know I have read that video is more effective, but not utilised very much because of the difficulties. And anecdotally, I find you get a lot more out of a video consult when you've got a good connection.
Yeah, true.
And Dimity's just made another question. Ordinary care plans, they do need a video consult as well. So the care plans, you need a video consult. So and sometimes that might be preparing it beforehand and then going through it with them, because it's hard to do the paperwork while they're on the video screen as well. So
yeah. So this next, was there any more, or happy to keep moving on?
Keep moving. That's great.
Yeah. Have we got much more time left?
So we've finished just before 8:30.
Okay, no worries. So this one is around your skin services. So determining lesion size for MBS item selection. So the necessary excision diameter or defect size includes the lesion size, a clinical appropriate margin of the healthy tissue needed for complete surgical excision, and to make sure that you take measurements before your excision. So you should also determine the margin size in line with the National Health and Medical Research Council guidelines. So I have included those links in that slide as well for you to have a read of. Oops. So there are histology requirements for skin service items. So to bill excisions, you must send the specimen for histo examination. So some items may allow a specialist dermatologist to confirm the lesion as malignant, but you need to ensure that you have met the MBS descriptor before billing this. So you must keep copies of your histo reports and any other supporting evidence, such as patient notes and photographs. So photographs should include a scale, and if you are going to be taking photos of lesions or rashes, whatever you have of a patient, it is important to either use a practice phone or camera. If you are going to be using your own, it is important to delete it as soon as possible. It's probably good to get advice from your medical indemnity if you are going to be using your own phone or camera. Billing re-excisions of malignant lesions. So you can bill a malignant excision item twice for the same skin lesion if it requires further excision. So you can use malignant skin items for the initial excision of the lesion and clinically relevant and re-excision. So you might need to re-excise a malignant skin lesion if the original surgical excision was incomplete or the margin wasn't adequate. So if you perform a re-excision, select the relevant item for the excision diameter based on the defect size. And skin services covered by an attendance item. So treating seborrheic keratosis by any means only attracts benefits under attendance item. and treating fewer than 10 solar keratosis by ablative techniques only attracts benefits under attendance items as well. Also, treating of warts usually only attracts benefits under attendance items, but there are some exceptions. So it is important to see the description of your item numbers and the explanatory notes for further clarification around those. Billing multiple services. So you can usually bill multiple skin service items if you treat more than one skin lesion on the same patient on the same occasion. So some skin service items are for treating multiple lesions. So if you treat a lesion described in one of these items, the item covers the treatment of all lesions. So if you bill for more than 2 procedures on the same occasion, you do need to note the exact location of each procedure on the claim. So if you're doing, say, lower third of the leg and right forearm, well, then you would need to annotate that. So an episode of care includes both the excision and the closure of the same defect, and this is true even when excision and closure are of separate attendances. So I have put some links in there so to read more about the billing multiple MBS items, and also if you bill multiple items, they may be subject to the multiple operation rule. So yeah, so there's some links there for you to have a read of. Aftercare, we'll have a look at now. So aftercare is the post-operative care and treatment provided to patients after an operation. So this includes all attendances under recovery, until recovery and the final check or examination. So aftercare services can take place at a hospital, private rooms, or in a patient's home. So the MBS fee for most surgical items in MBS include an aftercare component. So some MBS services don't include aftercare, but this will be noted in the description on the MBS. This is supporting mental health care, so your Better Access initiative. So the purpose of the Better Access initiative is to improve treatment and management of the mental health or the mental illness within the community. So Better Access aims to provide patients with access to the mental health professionals and a team-based mental health care. So under this initiative, Medicare benefits are available to patients for a selected mental health service provided by the general practitioner, whether it's VR or non-VR, psychiatrists, clinical psychologists, registered psychologists, and any appropriately trained social workers. So if you have registered for if you've done the component to the extended skills training, you do need to notify Medicare of that as well. So this is just a breakdown of your mental health item numbers and the frequency that you can claim them. So I won't go through all of those because we are getting a little bit pushed for time. Also, you've got a course of treatment, and so your maximum number of sessions that you can include in a referral, you do have your 6 sessions initially, and then it takes you to the 10 sessions after you do the review. So this is in a calendar year, and also as I mentioned earlier, they have increased the individual services to 20 services or 10 group services in a calendar year. So your calendar year is from the 1st of January to the 31st of December. This slide shows you when you're on the MBS. So where I've got the red box, you've got your news and your fact sheets. So every month they will update the news and also any new fact sheets that come out, so new item numbers or any changes to the legislation, they will update the fact sheet. So it's really important to keep an eye on those. And this one here is just a bit of a guide for combination billing, so what you can and can't bill together. So I've just added that little one in there to help you understand the appropriate billing. I've also included a few links in here, so feel free to go in, have a look, have a read up. There are some good training modules in amongst that. And also, don't forget, if you have any questions, whether it's today or tomorrow or whenever, feel free to just send me through an email. I'm happy to help you wherever I can. So I hope I got that all out in enough time.
Oh, that was great, Heidi. That was a lot to cover and some great little tips there.
It is.
And,
there was a lot, and sorry if it's overwhelmed.
No, we know where to go to, and that table at the end was very good. So I'll be laminating that. So, and I just made a comment too with the mental health plans. It can be quite confusing, and I suppose with the GP management plans, because we do them often, you know, it might be from June to June, but obviously the sessions are per calendar year, so it can get a little bit confusing. But from my understanding for the mental health plans, if all your plans and reviews are up to date, really the psychologist just needs a letter to state that we give permission that that patient can have an extra 6 sessions or 10 sessions under the COVID rule, as long as your care plans are up to date. Is that correct? Because I often get a patient coming in saying, I need permission, I need a review, but I did one a few months ago. So I just write a letter saying that I give permission for further sessions. Is that correct?
As far as I'm aware, yes. Yeah.
Oh, that was fabulous. Thank you so much. And
That's
just
okay.
before I hand back over to Jenny, just a reminder that next fortnight session is actually an evening session, and that's the Fitness for Drive session, which will be on in the evening on what date are we, Jenny? You probably know more about that. So you get a sleep in 2 weeks' time, but we hope to see you at that session on March the 23rd.
That's it.
Yeah, great. Yep. And again, please email me if you would like to host a session. And it doesn't have to be a big PowerPoint presentation. It can be just case study discussions. So if you've got a practice with a few doctors or registrars, would love to for you to run one of the morning sessions with some interesting case discussions or similar. So just email me. I'll put my email address in if you'd like to host a morning session. Thank you. Over you, Jenny.
Sorry, Jen, before you finish up, can I just ask,
Yeah.
did we cover all the questions in the chat, or do I need to go back and answer any of those?
I think we did.
Oh, I just saw Jeremy shared that screenshot from Proda. So thanks, Jeremy, for sharing that. That was the MBS item checker. So thank you.
Yeah, and the only comment Jeremy made was because I made the comment. So the asthma and diabetes item numbers are only really useful if you're co-billing with the GP management plan or a care plan review. But he made the comment it's also useful for AIHW data collection and future government funding, which is true. But with the drop of the sick payments, people wouldn't be billing them, so it's probably not accurate data collection anyway. So yeah.
Thanks so much, Heidi, for giving up your time this morning, and thanks, Sarah, as well. You've been a very great addition to Heidi's talk. Thanks everybody for coming. We have recorded the session. We will put it up in our secret little web page, and I'll send you all the link. I haven't put last fortnight's up because our comms guy has been away, but he's back now, so I'll make sure they both go up with a copy of the presentations. I'll just get the committee to stay on for a few minutes. And thanks everyone. And as Georgia said, the 23rd of March at 6:30 p.m. and it's Fitness to Drive. So thanks everybody and have a good fortnight.
Thanks everyone.
Thank you.
Jen, were you happy for me to go, or did you want me to hang around?